Hello, everybody. My name is Christopher Gresham, and I'm a professional athletic training student at the University of South Carolina. Today, I'll be presenting a critical review of a recent randomized control trial that explored the use of electrical stimulation to enhance recovery following surgery for severe cubital tunnel syndrome. Getting into our table of contents for the presentation, we're going to go through the background of the pathology, and then we'll break down the abstract methods and results of the research, and then we'll follow that with the discussion and clinical bottom line for future clinical practice. So for our background, cubital tunnel syndrome is the second most common peripheral nerve entrapment condition after carpal tunnel syndrome. It involves compression of the ulnar nerve at the elbow, often near the medial epicondyle, and it can lead to neurological symptoms such as numbness, tingling in the fourth and fifth digits, pain, weakness, and eventually muscle atrophy in the hand and wrist. The condition is graded on a scale from 1 to 3, with grade 1 involving only intermittent paresthesia and no motor involvement, and grade 3 representing the most severe form, which includes muscle wasting and significant motor dysfunction. Surgery is commonly used for grade 3 cases, but post-operative recovery tends to be slow and incomplete, and this has led to researchers exploring adjunct therapies such as electrical stimulation to potentially accelerate nerve healing. So for our abstract, this study was published in 2020 by Power and colleagues, which was a double-blind randomized control trial. Its purpose being to investigate whether applying electrical stimulation immediately after surgical decompression for severe grade 3 cubital tunnel syndrome could improve motor and sensory outcomes. The authors hypothesized that patients receiving stimulation would recover faster and more completely than those receiving a sham treatment. Getting into our method slide, 31 post-surgical patients with confirmed grade 3 cubital tunnel syndrome were randomized on a ratio of 1 to 2. 11 patients received sham or placebo stimulation, while 20 patients received 1 hour of real electrical stimulation using 20 hertz of biphasic current applied immediately after surgery. The electrode placement was in the same place for both groups, but no current was delivered for the placebo group. The study was double-blinded, essentially meaning that neither the patients or the outcome assessors knew which group each participant was in, and follow-ups occurred annually over 3 years. The primary outcome was motor unit estimation, or also known as MUNE, a sensitive electrophysiological marker of nerve reinnervation. Secondary outcomes that were assessed included grip strength, key pinch strength, and the McGowan grade, which is a clinical scale used to classify ulnar neuropathy severity on a scale from motor and sensory units. Getting into our results, the peripheral electrical stimulation group demonstrated significantly greater improvements across multiple outcomes. MUNE values were consistently higher across all follow-up points, including like the 1, 2, and 3 year annual follow-ups, indicating better nerve reinnervation. Grip and pinch strength also improved significantly at years 2 and 3, and additionally, more patients in the stimulation group improved to better McGowan grades over time, reflecting clinical progress. In contrast, the placebo group had much slower and less complete recovery. No adverse effects were reported with the stimulation protocol. Getting into our discussion, I found it notable that these findings suggest that a single session of peripheral electrical stimulation delivered immediately after surgery, can enhance nerve regeneration and functional recovery in patients with grade 3 cubital tunnel syndrome. The proposed mechanism is that 20 hertz stimulation promotes axon sprouting and encourages plasticity at the motor neuron level. Strengths of the study included its double-blind design, 3 year follow-up period, and the combination of functional and electrophysiological outcome measures. However, it's important to note that limitations included the small sample size, which only included 31 patients, the fact that it was a single center study, and the 1 to 2 randomization ratio, which could introduce baseline imbalances. Another key limitation is the lack of patient-reported outcomes, such as maybe a DASH or an activities daily life function. Getting into our clinical bottom line and overall take-home message, in summary, this study promotes strong evidence that the peripheral electrical stimulation can be an effective adjunct for surgery for grade 3 cubital tunnel syndrome. From a clinical standpoint, this may influence future post-operative protocols, especially in cases involving, again, that grade 3 entrapment. For athletic trainers, physical therapists, or even occupational therapists, these findings are relatively significant. They suggest that interdisciplinary collaboration around E-stim protocols may lead to better function outcomes for patients overall. Future research should include larger multi-site trials, including patient-reported outcomes, again, like that DASH or daily function and overall satisfaction post-surgery. This is the reference literature.